This hearing will come to order. I want to welcome all to the Budget Committee hearing, which will focus on our program and proposal for restoring the trust for all Americans. And this hearing is on those in or near retirement. This is a third in a series of hearings that we began last summer when this committee embarked on a new initiative, as I mentioned, called Restoring the Trust for All Generations. And this is an effort to raise awareness about the fiscal and policy challenges inherent in our health, retirement, and economic security programs. By focusing attention on these matters, we aim to build a broad consensus among our colleagues here, but also folks around the country, around the need to do something to save and strengthen programs like Medicare and Social Security so that today's beneficiaries and tomorrow's retirees have programs upon which they can count. Both Medicare and Social Security face real, substantial financial challenges. According to the most recent report from the Medicare and Social Security trustees, the independent folks who look at these programs from a financial standpoint, Medicare's Hospital Insurance Trust Fund is expected to be insolvent in 2028, 2 years earlier than was previously estimated. Social Security will exhaust its reserves in 2034. This is not simply an accounting challenge. With insolvency, Medicare will be able to cover only 87% of expected health care costs for beneficiaries, and Social Security recipients will face an immediate 21% reduction in benefits. Clearly, doing nothing is not an option. These are real folks' lives who are going to be affected if nothing is done. With 10,000 baby boomers reaching retirement age each and every single day, the number of workers paying into Medicare and Social Security is inadequate to ensure the long-term financial fiscal solvency of these programs as they exist now. In 1950, the Social Security program was supported by 16.5 workers for every retiree. You all know that that's a program where current workers pay for current retirees. That number is now 2.8 workers per retiree. We can lament this fact, but we can't deny it. The demographic and fiscal dynamics at play in both of these programs are a ticking time bomb, counting down to when the promise made to seniors will no longer be able to be kept. Surely no one believes that this is an acceptable scenario. Unfortunately, the financial well-being of the programs is just one of the challenges that we face. In Medicare and Social Security, if Medicare and Social Security were on solid financial footing, which they clearly are not, the programs would still be suffering from an antiquated and flawed design. In short, recipients are not getting the highest level of benefit and services that they could under a reformed system. Medicare's current structure is awkward and it's cumbersome. You have to sign up for 3 different separate programs in order to obtain essentially the same coverage that folks had the day before they entered Medicare. Even then, a number of Medicare enrollees feel obligated to purchase additional insurance to cover gaps in what Medicare is able to offer. Meanwhile, Social Security has not kept pace with an evolving economy and society. The program encourages early retirement, even though people are now working and living much longer than when the program was first started. As with so many of the challenges facing our nation today, the ultimate success of any reform effort lies partially with the health of our economy. But stronger economic growth is no panacea. It will not improve the structure of these programs or ultimately ensure their sustainability. It certainly will not make the programs more reflective of the needs of our senior citizens. With our Restoring the Trust initiative, we do not seek to dictate specific solutions. Our goal, rather, is that we aim to raise awareness and to promote important principles that ought to be a part of any effort to save and strengthen and secure vital programs like Medicare and Social Security. By focusing on the need for better choices, greater competition among those providing services to beneficiaries, and innovation across the board, we can and we will ensure health and retirement security for the American people. To help us discuss how best to achieve that goal, we're joined this morning by a distinguished panel. Dr. Jason Fichtner, a Senior Research Fellow at Mercatus at George Mason University. Dr. Daniel Weber, founder of the Association of Mature American Citizens. Dr. Scott Gottlieb, Resident Fellow at the American Enterprise Institute. And Dr. Monique Morrissey, an economist at the Economic Policy Institute. I want to thank you all for being here. We look forward to your testimony and a wonderful, constructive discussion to follow. Can't think of any issue that truly is more important to our senior citizens, yes, but to the nation at large and to our economic well-being. I'm pleased now to yield 5 minutes to the ranking member, Mr. Yarmouth.
Thank you very much, Mr. Chairman. Thank you for holding this hearing on this incredibly important topic. I also want to welcome all the witnesses testifying here today. You bring a diversity of experience and perspective that are important to this conversation. This is not a new topic for this committee. It's clear that America faces a long-term challenge when it comes to retirement security. I know my Republican colleagues are going to spend a lot of time talking about how Social Security and Medicare make up a substantial portion of the federal budget, which is true. But what they won't talk about, for instance, is the fact that corporate taxes as a share of federal revenue are at some of the lowest rates since the 1950s. I would argue that the wealthy should do more, which I believe is also true. But that is a debate we've had before as well. Today I want to talk about another side of this issue which we haven't focused on a lot, and that's the reality facing American families. The fact that far too many American workers find themselves in a lose-lose situation when it comes to planning for a secure retirement. Fewer and fewer employers are offering pension benefits, including the most prosperous businesses. Less than a quarter of Fortune 500 companies now offer traditional pension plans to new hires. Other companies are freezing their plans. On top of that, decades of wage stagnation, particularly for lower-income workers, have prevented these families from saving for retirement on their own or contributing more to Social Security. These workers who are critical to their employers and our economy, don't have the luxury of planning for retirement. Their priority is figuring out how to put some food on the table while also paying enough of their electric bill to keep the lights on. So yes, we have a fiscal challenge, but we have choices about how to respond, and our response should consider a broader landscape. The position of most congressional Republicans for many years has been that taxes can never be raised, not even by closing the most egregious loopholes that benefit the wealthy, to pay for spending commitments or deficit reduction. Instead, they have produced budgets that call for massive cuts in Medicaid, income security, non-defense discretionary spending, and other programs. Their budgets aim to make Medicare sustainable for the long term by turning it into a premium support program, shifting the financial risk of health cost growth from the federal budget to seniors and people with disabilities. For Social Security, if revenues are off the table, what's left is some version of the GOP vision that has been floating around since at least the George W. Bush administration. Cut benefits, maybe cut them a little more for higher earners and less for low earners, and try to make up the difference by encouraging private saving, once again shifting financial risks from the government to retirees. But that does not reflect the needs and priorities of the majority of the people we represent. I hope that today, as we debate these policy proposals, we take the time to really look and consider the painful fact that so many American families can't afford more and certainly can't afford to live with less. Thank you, Mr. Chairman. I yield back.
Thank you. Mr. Weber, Dr. Fichtner, Dr. Morrissey, and Dr. Gottlieb, we want to once again thank you for your time today. The committee has received your written statements and prepared remarks, and they will be made part of our formal hearing record. You will each have 5 minutes to deliver your oral remarks, and Mr. Weber, you may begin when you're ready.
Right here. Thank you, Chairman Price, Ranking Member Yarmouth, and members of the committee for inviting me to testify on the subject of Social Security and Medicare. I'm honored to testify before you, and I'm humbled to speak on behalf of the 1.3 million members of the Association of Mature American Citizens. Before I begin my testimony, I'd like to thank the entire committee and the staff on both sides of the aisle for the work that's been done on behalf of seniors nationwide. I, like millions of my fellow citizens, am worried about the looming insolvency of Social Security and Medicare. Will my benefits be cut? Will my benefits be enough for me to live off? Will I have access to the medical care I need? Will Social Security survive for my children and grandchildren? This series of hearings is a good first step to restore seniors' trust in their government. It truly is a time to restore the trust. By saving these social programs, as well as restore the nation's trust in its elected leaders. Thank you for inviting me to be part of this conversation. Rather than spending time reviewing the various statistics of which you are all too familiar with, let me summarize by saying what we all know. Social Security and Medicare are in financial trouble. Unless we act soon, I fear we'll be creating a culture of poverty within our senior communities. It's unacceptable to have such a negative prospect in the greatest, wealthiest country in the world. Seniors are both aware and concerned about the state of Social Security and Medicare. Every day, millions of aging Americans realize the sad reality that they cannot afford to retire. I know this better than most people, as my background and livelihood was based in insurance and pension planning. I sat across the table from hundreds of people who came to me ready to retire, only to find out how difficult it would be financially if they did. In fact, several of my own employees at AMAC are seniors who returned to work after they retired because they couldn't live on their combined Social Security and retirement income. Unfortunately, things will only continue to get worse. Today, the typical young person is competing against seniors in the workforce and will find it more difficult to retire than the generations before them. The social contract of the young caring for the old through Social Security program has turned itself into a generational gap and competition that leaves America weaker and less unified than ever before, and that's unacceptable. While AMAC largely focuses on Social Security and retirement, we also have been heavily involved in Medicare and the reduction of health care costs. As a benefit-providing organization, I constantly hear from my members about increased Medicare costs, the confusing nature of the Medicare program. My members are keenly aware of the fact that every year they pay more out of pocket for the same benefits that they've always had. The process of enrolling in Medicare is overly confusing and cumbersome. Personally, I know several people who've been penalized both monetarily and in coverage due to their inability to navigate the complicated Medicare system. Paying penalties and denying benefits to seniors when they have paid their whole lives into the Medicare program is also unacceptable. Medicare needs to be less complicated for the everyday American to comprehend and use. So what can we do? What am I, a concerned and affected senior, to do? We meet with our congressmen, we testify before Congress, and we activate the silent millions who want to see change for the better in our country. Well, like all great things accomplished in America's short but powerful history, solving these problems will require teamwork, bipartisanship, and a desire to do what's right. We need real solutions. I speak on behalf of the 1.3 million members in my organization when we say we want Congress to succeed. We want to fix these problems. We want you to restore the trust. AMAC has come up with fresh, bold, and new ideas to assist in any way we can. It's my hope that my testimony leaves a personal impression on each of you that Social Security is more than numbers, facts, and figures. It's people. People like me, people like you. I appreciate the opportunity to be here today, and I look forward to receiving your questions.
Thank you, sir. Dr. Fichtner, you're recognized for 5 minutes.
Thank you. Good morning, Chairman Price, Ranking Member Yarmouth, and members of the committee. Thank you for inviting me to testify today. My written testimony focuses on 3 key issues. First, the extent of the Social Security financial shortfall. Second, whether we're actually facing a so-called retirement crisis. And third, how the current structure of the nation's largest retirement program, Social Security, provides disincentives to work and save and is in need of modernization if the program is to fit the needs of the 21st century and achieve fiscal sustainability. From our discussion today, I hope to leave you with the following takeaways. 1, the Social Security crisis is not only real, it is already upon us. 2, painting all Americans with the broad brush of facing a retirement crisis creates an incomplete picture of the true financial landscape faced by many America's future retirees. 3, the narrative of a retirement crisis tempts us to look toward greater dependence on and the expansion of government programs, such as Social Security, which are already facing severe financial problems. And 4, Social Security is in need of modernizations. Reforms should not exacerbate existing problems. Instead, they should encourage saving and labor force participation. The Social Security Board of Trustees projects that the combined trust funds will be depleted in 2034. To further put this in perspective, the 75-year financial shortfall for the combined trust funds is $11.4 trillion in present value terms. If we indefinitely extend past the 75-year period, the so-called infinite horizon, the shortfall is a whopping $32.1 trillion. For comparison, our nation's gross domestic product is slightly over $18 trillion, and our gross national debt, not including unfunded liabilities, at the end of June was $19.3 trillion. And again, we're looking at a $32.1 trillion shortfall for Social Security. The original intent of Social Security when it was signed into law in 1935 was to provide income insurance against poverty in old age and to provide benefits to survivors of deceased workers. The key word is insurance. Insurance is designed to provide coverage against a high cost but low probability event. When Social Security was enacted, a small percentage of the population did not live many years past 65. But times have changed. People born today are living longer than those born when the program was created. Living longer is a good thing, trust me, but living longer creates a financial strain on Social Security because the retirement age is not indexed for increases in longevity. Social Security now has to finance more people over a longer period of time. Instead of an insurance program, Social Security is now a de facto national retirement program. That is an important distinction because those are quite different policy purposes. With insurance, the intent is to tap resources contributed by a larger group to protect a subgroup from an unanticipated income shock. By contrast, retirement programs are intended to benefit all participants. Increasing the challenge in the case of Social Security, the program now has to fund individuals for over 20 years of retirement based off the same number of years of worker contributions as when the program was originally created. Social Security's design has not kept pace with demographic changes or to reflect major changes in the workforce, including two-earner households and frequent job changes. Changing fertility rates also create a financial strain on Social Security's finances. In a largely pay-as-you-go financing structure, such as Social Security, the fertility rate has an impact on the number of workers providing payroll taxes to cover retiree benefits. In 1940, the fertility rate was 2.23, meaning a woman born in 1940 could be expected to have at least 2 children in her lifetime. The fertility rate jumped over 3 beginning around 1950 and peaked in 1960 at about 3.61. Today, however, the fertility rate has dropped to an estimated 1.87. To put this in context, around 1965, there were 4 workers for every Social Security beneficiary. The ratio has been declining ever since. It now stands at 2.8 workers per beneficiary, as Chairman Price noted, and is estimated to drop to 2.2 by 2035, the year after the combined OASDI trust funds are estimated to be depleted. The national newspapers are full of stories claiming that Americans are woefully unprepared for retirement. One such story was titled, "Our Next Big Crisis Will Be a Retirement Crisis." An often cited index of retirement preparedness claims that 53% of households are at risk of not having enough to maintain their living standards in retirement. I fully support efforts that will help Americans save for their retirement, but I want to stress that painting all Americans with the broad brush of a retirement crisis creates an incomplete picture of the true financial landscape faced by America's future retirees. It is important that Social Security reforms improve work incentives and promote individual saving while also addressing the program's financial solvency problems. Possible reforms include changing the cost of living adjustment, gradually raising retirement ages, adjusting the benefit formula, and constraining non-working spousal benefits for high earners. But we also need to think about retirement security more broadly than just focusing on Social Security. For example, providing payroll tax relief to seniors, increasing access to personal retirement accounts that expand choice and follow workers from job to job, and increasing financial literacy. Social Security faces real and increasingly urgent financial challenges. Reform is not only the wise thing to do, it is critical to ensure that Social Security remains solvent and fiscally sustainable and can continue to provide retirement security for generations to come. Thank you again for your time and opportunity to testify this morning. I look forward to your questions.
Thank you, Dr. Fichtner. Dr. Morrissey, you're recognized for 5 minutes.
My name is Monique Morrissey. I'm an economist.
Dr. Morrissey, you want to pull the mic towards you there, please?
Thank you, Chairman Price and Ranking Member Yarmouth and members of the committee for inviting me to testify. My name is Monique Morrissey. I'm an economist at the Economic Policy Institute and author of The State of American Retirement, How 401ks Have Failed Most American Workers. EPI is a nonprofit, nonpartisan think tank created in 1986 to include the needs of low and middle income workers in economic policy discussions. We face a looming retirement crisis. For the first time in modern American history, future generations will face a sharper drop in income at retirement than current retirees. This historical reversal is not because Social Security is broken, but because it has shrunk. It's also because we embarked on a failed policy experiment relying on upside-down tax breaks to encourage people to save for retirement while traditional employer-provided pensions declined. Social Security cuts implemented in 1983 reduced benefits by 19% for Americans born in 1960 compared with those born in 1936. In 1983, unlike today, Social Security faced an imminent shortfall. Congress responded with benefit cuts and by accelerating scheduled increases in the payroll tax rate. This seemed like a balanced response at the time, but Congress could not have anticipated that another leg of the proverbial retirement stool, employer pensions, was about to be knocked out from under working Americans. The previous year, in 1982, a few large employers had begun offering a new type of savings plan named after a section of the tax code that clarified the treatment of deferred compensation. These 401k plans were initially seen as supplements to, not replacements for, traditional pensions, though that is what they quickly became. The plans were popular with employers for obvious reasons. They shifted most of the cost and all of the risk of retirement onto employers. Meanwhile, some participants were lulled by rising stock prices, at least until the dot-com bubble burst. This was followed 7 years later by the financial crisis and Great Recession, which caused the net worth of the typical family approaching retirement to fall by half. Wealth measures are affected by factors that may have little impact on retirees' standard of living, such as fluctuating home prices. However, retirement accounts are part of, not an exception to, the wealth problem, as most families have little or nothing saved in these retirement accounts. The typical family approaching retirement had accumulated just $17,000 in a retirement account in 2013. It's $5,000 for all working-age families, but $17,000 for those approaching retirement. This is not enough to make an appreciable difference in their standard of living in retirement. Despite rules intended to limit the share of the tax benefit received by high earners, 1/5 of the population holds 3/4 of the wealth in tax-qualified plans. This inequality is not random. Some groups have fared worse than others. Most working-age Black and Hispanic families, as well as families headed by someone with a high school education, have no retirement account savings at all, and the same is true of unmarried people. Among all working-age families, 70% have less than $50,000, including 43% who have nothing at all. Meanwhile, the top 10% have $250,000 or more, and the top 1% have over $1 million. It was not always this way. We have gone from a retirement system that reduces inequality to one that magnifies it. Social Security has a progressive benefit structure with a higher replacement rate for lower-income workers. Meanwhile, traditional pensions at least did not exacerbate inequality. However, there are now more than twice as many workers in 401k-style plans as traditional pensions, and participation in 401k plans is very unequal. High-income families are 10 times as likely to have retirement accounts as low-income families. Moreover, retirement inequality is growing as the top fifth of households have seen gains in the new millennium, while the bottom 4/5 have lost ground. The problem is often defined as people not saving enough. However, more than half of households in the bottom half of the income distribution do not have access to an employer-based retirement savings plan. Others may have good reason to avoid a high-cost, high-risk system, since tax incentives for retirement savings are worth much more to taxpayers in upper tax brackets who can afford to take on more investment risk. What needs to be done? First and foremost, we need to reverse Social Security cuts and expand benefits across the board. To do this, we need to raise revenues by lifting the cap on taxable earnings and adopting other measures to expand the revenue base. I'm also in favor of slowly increasing the contribution rate to offset any increases in life expectancy. It's often suggested that we cannot afford to expand Social Security because of an aging population. It's true that the age dependency ratio is rising for a number of reasons, including the baby boomer retirement and a lower birth rate. But the dependency ratio is lower and rising more slowly than most OECD countries, and there have been offsetting factors. As a result, the United States does not face escalating Social Security costs as a share of GDP. Instead, benefit outlays are projected to stabilize at around 6% of GDP, 1 percentage point higher than today. So anyhow, I realize I'm running out of time, but I want to thank the committee for inviting me to testify, and I will respond with questions later if anybody's interested in the rest of my testimony. Thank you.
Thank you, Dr. Morrissey, and please, your prepared remarks will be made part of the record, and I know that folks have perused those as well.
Thank you.
Dr. Gottlieb, you're recognized for 5 minutes.
Thank you. Mr. Chairman, Mr. Ranking Member, thank you for the opportunity to testify today before the committee. My name is Scott Gottlieb. I'm a physician and resident fellow at the American Enterprise Institute, and I previously worked at the Centers for Medicare and Medicaid Services and at FDA. In addition to my responsibilities at AEI, I currently work with early-stage investors in healthcare and entrepreneurs who are developing new services and medical technologies. I want to discuss the ways I see Medicare policies creating obstacles to new innovation and the steps we can take to improve the environment for entrepreneurship so that beneficiaries can have more opportunities to access not only better treatments, but also more innovative healthcare services and better ways of delivering medical care. The only way that we're going to solve our long-term fiscal challenges when it comes to Medicare is to find ways to get more and better healthcare for every dollar of GDP that we spend on these services. And the only way we're going to improve the productivity towards achieving these goals is through innovation in medical products and healthcare services. When we talk about innovation in healthcare, we often have in mind technological improvements from new drugs and medical devices. But innovation also encompasses the structure and delivery of healthcare services and the way that care is delivered. These include better ways of organizing the business of providing medical services, but the inclination of CMS has been to openly scrutinize profit margins and adjust reimbursement schedules as a way to diminish what is seen as excess profitability, which seems to be anything above a 10% profit margin. This creates uncertainty and discourages investment in new services. These regulatory steps to set rates based on examining margins do not take enough consideration of the risk or capital needs that might explain why one subsector or service might need to trade at a higher multiple than another concept. On the drug and medical device side, one of the principal obstacles to new innovation is certain aspects of the prospective payment systems that Medicare has adopted for hospital, inpatient, and outpatient services. These payment formulas are meant to encourage providers to operate efficiently by offering a financial incentive to provide a particular service for the lowest possible costs and less than the fixed reimbursement rate. But the approach also puts providers at risk for the costs of the changes in technologies, which are typically introduced without adjustment to these fixed payment levels. As a result of all these influences, the pathways for innovation are more narrowly prescribed than they ought to be, often defined more by the prerogatives of government regulators rather than the vision of providers and entrepreneurs and the needs of patients. In healthcare services, it means that investors and entrepreneurs have backed away almost entirely from supporting new facilities-based and provider-based healthcare startups. When it comes to drugs and medical devices, these considerations create an ironic obstacle to new innovation. The areas of greatest spending or public health need are often those where Medicare seeks to apply more oversight and in turn more regulation. But that increased regulatory burden ultimately discourages entrepreneurship and capital investment for new innovations in those areas that could ultimately improve outcomes and reduce costs. Medicare regulators are well-intended and recognize the role for innovation in advancing health and improving the delivery of medical care. They're just responding to the rules that they're obliged to follow and the budget prerogatives that they're asked to pursue. The alternative is to break up the monopoly over these decisions and leave them to a more fragmented market of decision-makers who compete to offer consumers good prices and timelier access to the most beneficial services. This is much more akin to the private model that guided the creation of Part D and Medicare Advantage. As I outline in my written testimony, there are some more immediate steps we can take to reform the current program. First, we should consider certain reforms to new technology add-on payments in the inpatient side of Medicare and pass-through payments on the outpatient side of Medicare. The criteria for these payments are not defined well enough to create a reasonable expectation that any particular technology will qualify. That means that innovators largely won't factor these programs into their assumptions, so they have far less influence on entrepreneurship than they might offer. We also need to make the fostering of innovation a more prominent feature of Medicare's culture and responsibilities, much like it is at FDA. And we need to end the culture at Medicare that uses profit margins as a way to establish reimbursement schedules and penalizes profitability in new services ideas that have the most potential to improve productivity. Medicare's practices are discouraging risk-taking in products and services that fall largely within its influence. This is leading to an environment where innovation is increasingly being contrived to fit within a narrow set of parameters set out by policy prerogatives rather than the opportunities offered by science and the clinical aspirations of patients. Thank you for the time today. I look forward to the discussion.
Thank you, Dr. Gottlieb. Thanks to all for your testimony. I think it was it's a fascinating issues, fascinating topic, and you all have clearly demonstrated the need for our attention. I want to start by just stating the obvious, which is that the challenge is significant and it's real and it's near term. The fact that the Medicare is insolvent or going broke by 2028, and again, these aren't Republican numbers, they're not Democratic numbers, they're the Medicare trustees. And I think it's important for us to appreciate what that means, as well as Social Security, which is becoming insolvent in 2034. And those numbers, they change a little bit. They move 1 year this year, back 2 years the next year, and the like. but they're getting closer and closer and closer to us, to this time. And what it means when those programs are insolvent is that we talk about being unsustainable, and that means they will not be sustained, which means that we're not going, if nothing is done, we will not be able to provide the services and benefits to seniors in this country that they've been promised. And that, I think that's the key, that they've been promised. They've lived a lifetime, they've been productive, they've paid into these systems, and the assurance that they would receive a benefit from these programs, which we as a society said was important, that promise won't be able to be kept. We think that's not a wise path to take. So what I hope we're able to do with this hearing and others and the Restoring the Trust program is to get a consensus around that something needs to be done, and then we can have all the political discussions, all the conversations about what that something needs to be. But it's important that we start with the premise that something needs to be done. And I don't think anything's off the table. I know that my friend Mr. Yarmouth said that this is off the table, that's off the table. I don't think anything's off the table. I think we need to be creative, we need to be bold, we need to be expansive, and we need to make certain that our goal is to truly solve this challenge. And I hope it's done in a bipartisan way. I think if we work together, we can actually get something done. Mr. Weber, I was intrigued by your testimony about the complications of the programs themselves, the complication of Medicare. What is it that is, I mean, I've got some ideas, but what is it that you believe is so complicated about that program that makes it so that individuals are oftentimes penalized for signing up?
Yeah, just yesterday I looked at the Medicare website, and I looked at the instructions on signing up for Medicare, and I'd suggest we review that. And there were 3 choices, then there were 5 sub-choices, and then there were 3 or 4 points that you had to be aware of. I'll give you an example. Should someone who's employed sign up for Medicare, or should they keep their group health, for Part A? Okay, so now the question is, or Part B, what are the choices? What are the options? Well, you can't find that information on the Medicare website. So here's what actually happened to some folks I know. They didn't sign up for Medicare when they were allowed to, and as you know, there's a penalty. It costs more when you sign up later. They realized later that they should have signed up, and they signed up later, and they got this penalty.
Got dinged.
So that's just one example, because there was no counselor there to help them out.
So it needs to be much more user-friendly, if you will.
That's right. There's a second example. A union person signed up for a Medicare Advantage plan, and he didn't realize that once he left his union, he couldn't go back into the union plan. So when he realized the Medicare Advantage plan had limits on geography based on the network he was in, he contacted his union, said, I'd like to go back into my union plan, and they said, no, you've opted out.
Yeah.
So that's the kind of problem that we face. We get phone calls, and folks say to us, gee, can you help me with this?
Greater transparency. Good.
Yes.
Thank you. Thank you. Dr. Fichtner, you mentioned that the narrative that we currently have in Social Security encourages dependence, or encourages a lack of planning, I guess, if you will. Could you expand on that? I'm curious.
So part of the discussion, we've heard this in testimony today and various articles see about a retirement crisis coming, is people aren't prepared for retirement. They're not either saving enough, they don't have access to saving plans, they're relying more on Social Security is not keeping pace, wages aren't keeping pace. But who is that for? Is that for all Americans, or a small subset of Americans, or a large subset that needs help, but not everybody? When we talk about a retirement crisis, the narrative seems to think that we are all doing poorly. Dr. Morrissey mentioned something about the upside-down nature of retirement savings plans like 401ks, and I completely agree with her, and I've testified before Congress on the need to change the deduction to a credit to help lower-income workers. What we look at now is there are people who need help with Social Security, but not everybody. Bill Gates does not need help. Warren Buffett does not need help. I'm not going to need help with Social Security, but there are people that are struggling. But we need to look at changing the nature of the program, both Social Security to help those at the bottom end, without expanding benefits at the high end for high-income beneficiaries.
Do you believe that folks ought to be able to opt out of Social Security?
The plan entirely, it's an insurance program. I think we're way too far in the system now to go backwards and completely remove it. I don't think that's a possibility in our society. What I would like to do is see more choices and options for people to have better access to private retirement plans that move with them, and then shore up the insurance portion of Social Security, both retirement, disability, and survivors and widow benefits.
So for you personally, you would prefer to have greater flexibility in the program?
Yeah, I would definitely prefer greater flexibility. But what I would point out to people right now is the program for retirement security, the way we have a Social Security system, sometimes we have a defined benefit plan for employers and employee systems or a defined contribution. For people like me, it's working just great. I can maximize my contributions to my 401k. I'm going to get full benefits for Social Security if we can solve it and don't get a benefit cut when I retire. And I've got a partial DB plan as a former employee of the United States Congress and also United States Social Security Administration and IRS. I have a DB plan as well. I'm doing fine. Yeah. But the point in here is we're not here to talk about me doing better. It's how do we help those who need assistance.
Exactly.
And the retirement crisis paints a broad picture that is inaccurate.
Thank you. Dr. Gottlieb, I appreciate your work, and I'm intrigued by this notion that innovation isn't just needed for innovation for quality's sake, but innovation is needed for a fiscal sustainability of the program. And I wondered if you would innovation in sites of treatment, innovation in all aspects. Share with us a little more about the innovation, not the specific healthcare quality portion of it, but the provision of the care.
Right. I think when we talk about innovation, we usually think of new drugs and medical devices, and they obviously have a role in improving outcomes and improving productivity of the overall system. A lot of the increases in productivity have come from technology inputs offsetting services. What we don't think about is innovation in healthcare delivery and healthcare services. And if you look at all the great innovations that have happened in how we organize care, whether it's outpatient dialysis or skilled nursing facilities or home infusion centers or surgical centers, those all were started by entrepreneurs. Each one, practice management companies, the first for-profit HMO, each one of the things that I just mentioned was a for-profit entity started by, in most cases, venture capitalists, sometimes private equity or growth equity, and the concept worked and became a more mainstream concept, and in many cases they were adopted by bigger institutions, including hospitals. So I think we lose sight of how we've actually innovated in organizing the delivery of healthcare services. And what I worry about now is we have an environment where these are very capital-intensive endeavors. A facilities-based or provider-based startup is very capital-intensive, and there's virtually no capital going into that. And I worry that we have an environment where there's an expectation that the innovation is going to come from these consolidated health systems and hospitals, and that's not traditionally where innovation in healthcare delivery has come from. It's actually come from startups and entrepreneurs, the same way it comes about in other parts of the economy.
Isn't it true that Medicare, the innovations that you just talked about, whether it's outpatient surgery or the like, isn't it true that many of those aren't currently available to seniors because of the way that Medicare pays?
The problem with a lot of those the services, and especially new services, is that, if you're an entrepreneur starting a new entity, you have to get in and get out quickly enough before Medicare will punish your profitability, because literally Medicare, as I mentioned in my testimony, scrutinizes, and MedPAC does this too, will scrutinize profit margins as a way to try to determine reimbursement schedules without enough appreciation, in my view, for the risk or other reasons why one sector might need a higher profit margin than another in order to be sustainable. These services, a lot of them aren't readily available in fee-for-service medicine, and a lot of the services I've talked about, the ones that haven't been fully sort of incorporated and mainstreamed into the system, are now struggling. You see some of these standalone entities struggling. A lot of the capital is going into healthcare services, and there's a lot of it, but it's all going towards healthcare IT and other things that aren't capital intensive. And the other thing is that a lot of the money that's going into healthcare services now is going into concepts that don't face Medicare. So the reason why healthcare IT is attractive is because it faces providers and it faces patients, but not the Medicare agency.
Yeah, no, I appreciate that. You mentioned that Medicare punishes productivity, which ought to be a red flag and alarm bell for all of us. So thank you. We'll have some follow-up questions that we'll get in writing if they're not addressed by my colleagues here. Mr. Yarmouth, you're recognized. Mr. Pocan, you're recognized for 5 minutes.
Great. Thank you, Mr. Chairman, and I'd like to thank the ranking member. I think the one thing we all agree is that if we do nothing, we're going to have problems. I'd like to focus mostly on Social Security because I'm one of those people who grew up in a lower middle-class family. My father had a heart attack in his early 40s, so had some limited income potential. My mom worked until she was 70 after he passed away a decade earlier. on the floor a couple years ago. I did her bills. Luckily, she owned a home since the 50s. She had her 1999 car still with plenty of scratches around it, and she got $1,101 a month. And I laid out her bills, and because she owned her home and car, she was only a little bit underwater based on that Social Security income. But I think that's the reality for the vast majority of people who live in our district. So I just wanted to focus on a couple questions, and Dr. Morrissey, if I could start, because I think you started to go to this. I'd like a little more information, if you could, on when, if we lift the cap on income for Social Security, what we tax, when was it last increased? What level would it be by inflation now, and what kind of extensions do we get out of various lifting of the cap on taxing for Social Security?
Well, it used to be that it was a happy answer. We could say, well, you scrap the cap, you've basically solved the shortfall, and that's no longer true. And to be honest, I don't know the answer off the top of my head, but I know that we do need to do more than just lift the cap, especially assuming that we're also going to increase benefits for the people who are paying more into the system. And I think so, therefore, it's necessary not just to lift the cap and broaden the base to include other forms of income in taxable earnings. So that's another big part of it, is that capital income is not taxed, and capital income is a growing share of the economy. Also, the rising healthcare costs are another factor that's eroding the revenue base. So we need to address all of those issues. And then in addition to that, I personally believe that we will need to, at some point, slowly raise the payroll tax rate, which I just want to emphasize has not been increased since 1990, and it used to be increased fairly regularly. And the reason I think it's important to note this is that people are often very afraid of life expectancy. They think it's going to be rising very quickly. But if you increase the payroll tax contribution just enough to offset life expectancy, it rises so slowly, it's imperceptible. It's negligible compared to rising wages. So the projections of rising wages completely swamp any increase that would be required to offset the increase in life expectancy. But I will answer your question offline as soon as I have it. I haven't looked at the latest numbers since the trustees report.
Appreciate it. And then to those rising healthcare costs. So when I talk to my mom, she's going to the doctor every week, or at best every other week, and I probably go once or twice a year. The CPIE, could you talk more about the CPIE as a different way to index the payments for Social Security?
Yes. Well, one of the things, I mean, there are aspects that I agree with my colleagues on the panel here about antiquated systems, and one of the things that's antiquated about Social Security is at the time that Social Security was, the COLA was implemented in the 70s, there was only one cost of there was only one price index available, and it was a price index for urban worker, for workers. And that, in fact, it actually specifically excludes seniors from the population whose spending habits are considered for the price index. And so we need, and seniors specifically spend a lot more money on health care. And historically, the CPIE, which is an experimental index that takes into account seniors' spending, has risen much faster because healthcare costs have increased faster. In recent years, there hasn't been as much of a divergence between the CPIE and the CPIW, but nonetheless, I believe, as I believe you do, Mr. Pocan, that Congressman Pocan, that we should be indexing benefits to a basket of goods that seniors are spending, and services that seniors are spending money on, and that disproportionately includes health care. And I expect that even though healthcare costs have slowed down, that they're still going to rise faster than overall inflation. So I think that's a very good idea.
Right. And in the 45 seconds we'll have left, ways to strengthen Social Security, what are some recommendations you have?
Well, I like you, believe we should scrap the cap. We should expand the revenue base. We should, I believe in an across-the-board increase in benefits. I believe there's sort of an upside-down system here where a lot of conservatives are now talking about a more progressive, more targeted system that looks more like a safety net. But I believe that we already have a safety net, and it's been devalued. We have SSI, we have the special minimum benefit, and they've been grossly neglected. I think the strength of Social Security is that it's a universal program that everybody feels that they have a stake in. And so I think we need to expand that. We basically need to reverse the 19% cuts and then expand from then. And we need to do it in a way that everybody pays in more and everybody sees a little bit more in benefits because they need it more than ever.
Thank you.
Gentleman's time has expired. Mr. Renacci, you're recognized for 5 minutes.
Thank you, Mr. Chairman, for holding this important hearing to discuss the sustainability challenges of Social Security. I want to thank the witnesses for being here. Like many of my colleagues, I often hear from my constituents talking about the need to preserve Social Security and ensure it remains a reliable source of income for retirees. I agree. As a father of three, I believe that we have a responsibility to leave our children and grandchildren with a country that is financially stronger than the country that we inherited. Unfortunately, Washington too often chooses to kick the can down the road and fails to address the long-term challenges that our country faces. The 2016 Social Security Trust Report should set off some alarm bells. That report finds that the present value of the 75-year unfunded liability in the Social Security Trust Fund is $11.4 trillion. That's $700 billion increase from last year's report. This dollar amount represents the present value of the financial shortfall between the amount of revenue of the trust fund will collect and the amount the trust fund owes the Social Security beneficiaries. Unfortunately, as Washington delays addressing the problem, the outlook continues to worsen. In fact, since 2009, the 75-year shortfall has more than doubled from $5.3 trillion to the current $11.4 trillion today. This is a serious problem that will require difficult decisions to be made. Before tackling these problems, members of Congress must first start by fully recognizing the problems we face financially as a country. That's why last week I introduced a bill with a bipartisan working group to bring further awareness to both lawmakers and the American people of the unfunded liabilities and obligations our country owes to all of our social insurance programs. Our nation's finances are one of the most important pieces of information that lawmakers should consider when setting the policy agenda for each Congress. But too often, I believe that many here in Washington ignore or willfully blind to the subject. We are not $19 trillion in debt. When you add the social programs, the unfunded social obligations, we are closer to $80 trillion in debt. This bipartisan legislation simply requires the Comptroller General of the United States to present a financial report of the United States in a joint session of Congress. This will be held 45 business days after the issuance of audited financial reports to ensure lawmakers receive the information in an accurate and timely manner. I hope many of my colleagues will join me in this effort, as I believe that members of Congress and American people need to fully understand our country's unfunded obligations. That needs to be our starting point, everyone recognizing the problems. Dr. Morrissey, I appreciate your comment because I know the ranking member was talking about raising taxes, increasing taxes. We had a Social Security subcommittee hearing. Basically, the information that came out is that if you eliminate the cap, you're not going to fix the Social Security shortfall. It also said that if you increase the tax base, you're going to have to increase it on everyone. And you also said that, so I appreciate those comments. I want to make sure everybody is reminded, when you say increase on everybody, that's the lower earned wages too, and the middle class Americans, which if you're going to fix the problem, we have to look at everything. And I'm not even saying we need to, I support those ideas. I just want to make sure all members understand the fix is not easy. And I appreciate what the chairman of the committee said. All ideas have to be on the table. But we can't just say we're going to go after the wealthy, because taxing the wealthy is not going to fix the problem. Raising the cap is not going to fix the problem. We have a lot of things we have to look at. So this idea of attacking the wealthy or raising taxes on the wealthy is not the answer. It's got to be a number of things. Dr. Fichtner, can you talk a little bit about the importance to consider proper accounting? I mean, this unfunded liability issue drives me crazy because nobody wants to talk about it. Everybody wants to talk about $19 trillion, but that has to be our starting point. I'd love to hear some of your comments about it.
Well, Mr. Renacci, I don't mean to scare you, but you mentioned the GAO's $80 trillion fiscal gap figure, but some estimates by Larry Kotlikoff put the figure at $210 trillion, so a lot more than 80. What we do now is we look at basically three measures of debt. You've heard debt held by the public, which CBO likes to use, and that's a measure of what we've already paid out for programs in which we have not raised enough revenue to cover, and that stands around $13 trillion. The $19 trillion is gross debt and includes trust funds like Social Security and Medicare, which have trust fund balances, which by law we have to put any excess revenue from payroll taxes into treasuries. So they are a future obligation on our debt. But that does not represent the total unfunded liabilities, which is what's coming down the pike. And that's the $80 trillion or $210 trillion that you've referred to. And that's a more realistic net present value calculation. In other words, if we had to be a defined benefit plan, like most private corporations that run have to have money up front to cover benefits, if the United States government was held to the same standards as a private company, how much money we would need today in the bank to pay for those benefits we've promised, as Chairman Price mentioned, It's a minimum of $80 trillion, but it's upwards of $210 trillion.
Thank you, Mr. Chairman.
Gentleman's time has expired. Gentlelady from Florida, Ms. Castor, is recognized for 5 minutes.
Well, thank you, Mr. Chairman and colleagues. We have an important responsibility to strengthen Medicare and Social Security, so thank you for calling the hearing today, and thank you all for your testimony. Dr. Morrissey, your testimony was very interesting because looking back over decades and watching what has happened to people's retirement security, you know, it used to be that working Americans, more and more working Americans could count on a pension that would be there for them when they retired, and then Social Security was what they paid into, but it wasn't what they relied on for their security in their retirement years. Could you detail that a little bit more? What has happened to jobs with pensions over the past, say, 3 decades?
Well, right around the time that we were cutting Social Security in 1983,
Dr. Morrissey, you want to turn on your mic, please?
I'm sorry. Coincidentally, at exactly the same time that we did the last cuts in Social Security, we introduced these new kinds of plans. They were sort of accidental. Congress did not intend them to be something that replaced pensions, but in effect, that's what happened. The overall share of workers who were covered by any kind of employer-based retirement plan was essentially did not rise, even though these plans were easier to provide. It stayed at about half. So really, it was like a one-for-one replacement, 401k plans replacing pensions. And then it's even started to decline. In the new millennium, at first we weren't sure if it was a glitch, but now it seems to be a downward trend. So ironically, these plans that are easier to provide for employers are actually less, we have fewer workers covered. But more importantly, they're also they do much less for workers. And one of the things I'd like to point out is that the date when 401ks really became the dominant plan can be debated, but essentially in the early 90s, 1992. So it's been a quarter century since they've been the dominant plan, not just in the private sector, but in the overall economy. And yet, retirees today still receive 6 times as much income from pensions as they do from 401k plans. So these things really are not providing a meaningful amount of income to any current retirees. People say, well, that's going to increase in the future because 401k, replaced pensions, but really not in any way, not nearly enough and not nearly fast enough. And I mean, I agree with some of what Dr. Fichtner said, but one of the things is when we say that we can cut Social Security and rely more on savings, we've tried that. It's an experiment, and it's a failed experiment. I mean, I'm glad that he agrees that we should fix we should change it to refundable tax credit instead of, I mean, we should talk, I mean, I know this about him anyhow, but there are things that we agree on, but I do not believe that fundamentally we'll ever create enough private savings to replace lost pensions and lost Social Security benefits.
Maybe you all, that would be a helpful example for us. Maybe if you all could put your heads together, make some solid recommendations to the committee, I would appreciate it. I'm sure my colleagues would as well. Dr. Gottlieb, I appreciate your focus on innovation in healthcare. I was surprised that you did not focus on pharmaceutical costs as a way to shore up Medicare, because that is a place where there is a great consensus, maybe not here in the current House of Representatives, but prescription drugs are a huge cost to Medicare and to consumers. And let me tell you a story about a doctor from home in Tampa was visiting up here just a couple of weeks ago, and he said, I'm really confused about federal policy on this. I treat veterans every day back home, and then I see Medicare beneficiaries, and in many cases they have the same medical conditions. I prescribe the same drugs, but it costs so much more in Medicare because there's this silly federal law that says Medicare cannot negotiate prices while we're able to achieve big savings. In fact, Medicare Part D pays on average 73% more than Medicaid and 80% more than the Veterans Health Administration for brand name drugs. Some studies say that we can save $16 billion a year, and some studies say up to $40 billion a year. Isn't this an area where we should focus on to achieve some long-term savings for the Medicare Trust Fund and consumers and beneficiaries?
Thanks for the question. I certainly agree with you. It's an area we should focus on. I think when you look at Medicare Part D generally, because of the competition between the different plans and the PBMs that supply the benefit, a lot of the prices in Medicare Part D are actually lower for beneficiaries in Medicare than they are for people in the United Kingdom where prices are set by the government. That doesn't mean we don't have some challenges with drug costs. And I think the two places where we see high prices and rising prices are the cost of what I would call generic specialty drugs and also single source, highly innovative drugs. I think on the generic specialty side, and I've written about this, I think that there are certain regulatory challenges that prevent as vibrant competition in the generic drug space as there ought to be. And so you have a lot of old generic drugs being sold as specialty drugs that shouldn't be, that should be subject to vigorous competition. I think on the single source, highly innovative drugs, the drugs that are having a real impact on diseases like cancer, I think we need to be careful about imposing government controls on pricing that might set the wrong incentives and might force us, like a lot of European nations do, to overpay for the least innovative drugs and underpay for the most innovative drugs. That said, I think there are steps we can take to try to make the pricing more competitive for these drugs by allowing these drugs to be priced on the basis of how they're being used, on the basis of the indication, on the basis of the outcomes they're supplying. And here again, there are a lot of government impediments to that. And I just wrote an article in Health Affairs 2 days ago with Dr. Kavita Patel at the Brookings Institute, who worked for the Obama administration and for the late Senator Kennedy, on some of the reforms that we could impose in the Medicare program to allow prices to fluctuate more in this regard. And some of those ideas, just in closing, are incorporated in the current Part B rule. I have a lot of concerns around that rule, but there were some good ideas in that rule, including some that we echoed in our paper.
Thank you. Gentlelady's time has expired. Mr. Johnson, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and I thank our panel for joining us today. You know, this is one of the most important issues that Congress and our nation at large has to deal with. I can tell you I represent thousands and thousands of seniors along the Ohio River that are very, very concerned about the sustainability of our safety net programs. I've got an 84-year-old mother, and when I first came into office in January of 2011, her first phone call to me was not to say congratulations. It was to say, okay, now what are you going to do to make sure that my Social Security and Medicare are protected? Because if they're not, I'm coming to live with you. And so it gave me a strong incentive to I love my mother, but she turned me loose a long time ago, and I want to keep it that way. So let me ask you, Dr. Fichtner, do I have that right?
It's Fichtner.
Fichtner, okay. How should physical health in the Social Security program be measured? The trustees that estimate that the program will be insolvent in 2034, what does that actually mean to seniors who will be drawing benefits during that time?
Mr. Johnson, you make an interesting point about making sure that your parents don't move back in with you. And the Social Security Trust Fund is scheduled to be depleted in 2035 is a little bit short of when I want to retire, and I'm sure my mother doesn't want me to move back in with her either. And fiscal health for Social Security means that we have enough revenue coming in to pay benefits. And under current law, so if nothing is done by Congress or the President, if we don't do anything, by law, benefits will be cut around 2035 by about 25%. So that means
it will not take congressional action to cut those benefits, right?
it happens automatically unless Congress does something to stop it. And I think that's the important thing we need to discuss right now. When we think about the idea of what does that mean for reform, there's something called scheduled benefits and payable. And there's a big delta between the two, about 25% right now. So if Congress does nothing, there won't be enough revenue to come in to pay fully scheduled benefits. The payable amounts to about 74 or 75%, which means everybody, those who are wealthy and getting benefits, those who are poor and getting benefits, we get a 1/4 or 25% cut in benefits if we do nothing.
Okay. Mr. Weber, we talked about Social Security there. We have a very similar and actually a more immediate problem with Medicare. In your view, are seniors really aware that Medicare is expected to be insolvent in 2028?
No.
Social Security, we talked about 2035. And at which point will the programs begin to have to cut benefits without congressional action? Is it going to be right up until the deadline, or will they begin to feather back, throttle back earlier?
Yeah, unfortunately, most seniors are unaware of that, just like they were unaware of the impending problem with the disability income portion of Social Security. And then at the last minute, the Congress came out with a fix, a temporary fix for the disability income, which was scheduled to go start reducing benefits at the end of this year. So I would say our average member has no knowledge of that. We talk about it, and recently we held a town hall. We had 200 people attend, where we went into details about Social Security, and I'd say the average attendee was shocked at what they heard.
Yeah, I'm concerned about that the message is not getting out there. We're saying it, but it's coming across as a political statement, not as a reality statement. And
That's right.
I don't think they get it. Dr. Gottlieb, what role does Medicare serve in enhancing medical innovation and the adoption of new medical technologies, cures, and therapies?
Well, it plays an outsized role, so in some cases good, in some cases to the detriment of medical innovation. I mean, programs like coverage with evidence development, where Medicare will cover new technology but require additional evidence development that can guide more appropriate use of a technology down the road, I think have been useful sort of policy innovations that the program has put into place to try to smooth the introduction of new technology. But there's a lot of places in the Medicare program where it's an obstacle to innovation, and sort of the culture of Medicare. You know, when I worked at FDA, there was a real sense of public health mission there, and that was the culture that guided the agency. The culture that guides the CMS, and it's not to say they don't have a sense of public health mission, they certainly do, but the culture is the trust fund. That's what drives folks, is the idea that they need to preserve the trust fund, and that really is the esprit de corps of the agency. And so that leads to decisions to try to, I think what they would argue is smooth the introduction of new technology, and what I would argue is actually impede adoption of new technology.
All right, thank you, gentlemen, and ma'am, for your testimony. Yield back.
Mr. Yarmouth is recognized for 10 minutes.
Thank you very much, Mr. Chairman. Thanks again to all the witnesses. It seems to me that within the testimony of collectively that we've heard today, there are little nuggets of things which illustrate a point that I'm constantly reflecting on, and that is that when we talk about these programs, Social Security and Medicare specifically, and particularly when we do it in this committee, we talk about them as if they exist in a vacuum, that we're engaged in just an actuarial exercise, that certain people are going to turn 65 and then they're going to live this long and there's this much money and so forth. And we don't focus on kind of the global impact of all sorts of other factors. We talked about income levels. Clearly, if income levels were throughout one's career were higher, then the amount of revenue going into these systems would increase, and that would change the equation. Similarly, if we had better health care for people from the time they were born until the time they turned 65, then the cost to Medicare's trust fund would presumably be lower over time because we'd have healthier citizens participating in that system. And I was particularly encouraged to hear Dr. Gottlieb talk about some of the issues that are kind of industry-wide or universe-wide in healthcare in this country, particularly things like innovation, and I think of research and what a difference it could make for all of these forecasts if we were able to cure Alzheimer's, if we were able to figure out a way to either cure or very effectively manage diabetes, these things that cost hundreds of billions of dollars a year to the system. So again, I don't think we can just look at these as actuarial progressions, as Dr. Fichtner knows well, and say that these are the answers to the system, because we do have global options available to us and things that we ought to be focused on. And one of the things, Dr. Gottlieb, that you talked about, which has been a pet peeve of mine, is CMS's obsession. I guess they're forced to deal with profit margins as a standard for how they set prices. And I remember sitting in a Ways and Means Committee hearing back during the debate on the ACA, and throwing a hypothetical at one of the witnesses from CMS, and I said, now, in my community, you can get a colonoscopy at a freestanding endoscopy clinic for, at the time, about $700. That same colonoscopy in a hospital was $3,000 to $4,000. I said, so let's say hypothetically that each of them makes $100 on the procedure. So the hospital's profit margin is about 1/6 of the freestanding endoscopy clinic, yet the system is being charged $3,000 more. And I said, how can we justify anybody going to the hospital for that procedure, particularly if the government's paying for it? And he said, well, the problem is if you eliminate that revenue stream to the hospital, then they're going to have to raise prices on something else. And my response was, that's not an answer, that's an indication of a broken system as far as I'm concerned. And so I do want to get to one other thing which you did not mention, and again, one thing that I'm concerned about, and that is, again, this is not just Medicare, this is the entire healthcare system, is the consolidation of power and resources and personnel in hospitals throughout the country. In my district, we have fewer than, and I'm Louisville, Kentucky, I'm a heavy urban area, we have fewer than 50 family practice, individual practitioners of family practice in the entire city. Every other practice has been bought up by a hospital. Can you talk about whether you see that as a problem that might help deal with some of these projected deficits, and whether that's something we ought to look into?
Well, look, I think that the local market consolidation, people focus on the consolidation between big providers, hospital chains, and HMOs, and I think the biggest single problem in healthcare right now is a local market consolidation, because at the end of the day, all healthcare is local, and we've created local monopolies by consolidating physicians around these local health systems. Now, we've taken policy steps to deliberately drive that consolidation, and it was done to try to achieve other policy goals, including trying to transfer risk to providers through forms of capitation as a way to create different economic incentives in the system. And it was viewed that hospitals were the most likely vehicle and the sort of available vehicle to consolidate physicians and create systems that were big enough to take capitated risk. So we've made a deliberate policy choice as an administration and people in Congress and other policy thinkers, but I think it's going to have a very detrimental effect. And the other thing I would just say in closing is we did this in the 1990s, where there was a wave of consolidation of providers around hospitals, and those relationships became unwound when it was realized by the hospitals that it was unprofitable to own physicians and try to run these large health systems. I think these current relationships are going to be far more durable. I don't think the physicians are going to go back to building practice by themselves when these relationships become unhappy and unprofitable. I think the hospitals will just burn the physicians down to a point at which it makes economic sense to continue to have them. Remember, going back and starting your own medical practice again isn't as easy as getting a new tax ID. The hospital will own your medical records. Doctors are going to be locked in these relationships. And once we end local market competition, which we're doing, prices are going to start to go up and choice is going to diminish.
Thank you very much for that. And also, I know there are incentives in the law that are, in my vision, or in my perspective, are very, very backward. For instance, the requirement that in order for Medicare to pay for rehab services, you have to spend 3 nights in a hospital. Does that type of incentive make any sense? And is that the type of thing we ought to be looking at as well?
Well, look, I think you have to look at all these things, and this is, in my view, from my view, this is the problem with trying to administer a program across a very diverse nation, a very complex program across a very diverse nation, which is that you have to set binary rules, but those binary rules have a lot of unintended consequences. Just for my own clinical practice, I practice as a hospitalist. I admit patients through the emergency room, and the sort of rules around patients who were admitted or who could be staying in the emergency room for less than a 24-hour stay. All of a sudden, you had all these patients staying in the emergency room for 23 hours because the hospitals didn't want to have to book the admission. So it creates a lot of unintended consequences in terms of how doctors are forced to try to treat patients. You cite one example, you have to keep a patient in the hospital longer than you might otherwise want to so they can qualify for an admission to a rehab facility. I have another example. We can go down a list and cite dozens of these examples. This is a consequence of trying to deliver a very complex benefit from a remote location on Security Boulevard for a very diverse nation.
Right. Thank you very much for that. Dr. Morrissey, going back to this whole idea of the adequacy or inadequacy of Social Security benefits and retirement projections and so forth. I mean, I looked up the numbers just in for median net worth in the country, the last numbers that were available, white families, $141,000, black families, $11,000, Latino families, $13,700. Clearly not enough to even withstand the slightest bit, a new roof that you might need on your house. And these are numbers that I assume include cars, furnishings, home equity, whatever it is. So
Yeah.
these aren't even liquid savings. These are things, and that's why you have ads on television for reverse mortgages and those types of things which try to create liquidity out of assets. So what would, if we were actually to reduce Social Security benefits or freeze them, what would be the impact in terms of on poverty rates and basic standard of living for the vast majority of Americans?
Well, I mean, the poverty rates would rise astronomically, and I think that it's important to recognize that basically savings have not gone up, even though we are now relying on private savings to replace lost pensions and lost Social Security benefits. And so I don't think this has always been the case. Essentially, we talk about a proverbial three-legged retirement stool, but it's really always been Social Security and pensions, and savings was basically your house. And a lot of people don't have, renters don't have houses, but also even if you own a house, it doesn't necessarily mean you have a lot of home equity or it's accessible. We also find that seniors are loath to tap. They view what savings they have in their home as usually sort of a last-ditch thing, so very rarely tapped unless they're widowed or they go into a nursing home. But otherwise, it's really viewed as inaccessible. It's precautionary. People are very nervous about tapping their retirement. And basically, we found already that half of the population is not ready for retirement, according to very conservative estimates, in my view, by the Center for Retirement Research. And these estimates always assume that people do tap their home equity and go down to the last penny before they retire. And that's one of the ways that this is an unrealistic assumption. People just do not do that on average. And so yes, we would, and so I believe that, basically one of the reasons, we talk about how we're living longer, we need to, work longer. People are already working longer, people are trying to save more, but they're trying to fill a bigger hole. The bigger hole is because of lost pensions and because of lost Social Security. So we don't need to be digging that hole any deeper. People do need to save, but they need to save to make up for what they're losing.
Gentleman's time has expired. The Vice Chairman, Mr. Wakita of Indiana, is recognized for 5 minutes.
Thank the Chairman. Again, thank you for conducting these hearings. I find them very beneficial and educational. Mr. Weber, I'm interested in your town halls. I do a lot as well, and I also learn a lot at them from my constituents. But part of being a representative is that you also share information. And I'm a bit of a scrapper, too, so I don't mind them. But I'm interested, surely a response at your town hall was something along the lines of, well, we wouldn't be in this mess, debt or otherwise, if they didn't steal that money out of the fund.
Sure.
What was your answer?
Well, there's a lot of misinformation, and there are a lot of facts that point to those things. The real problem that we see is the Congress hasn't acted in a timely fashion. And let me just address something that Dr. Morrissey said, that the 401ks are not doing the job. Would you agree? And the reason for that is when you had an old-fashioned pension plan, you couldn't get at that money until you retired. With 401ks, people can raid that money before they're ready to retire. So if you want to make sure people can save more money for retirement, don't allow them to borrow money or to cash in money from a 401k.
Thank you for that point. I want to get back to this. It's the Social Security Trust Fund, et cetera.
Sure.
Now, it's also true, Dr. Fichtner, then, that even though there's IOUs in the fund, that fund is getting interest on those IOUs, and those IOUs are being paid back. So the fund is actually making some money on those IOUs.
Well, it's sort of like your left pocket paying your right, Congressman.
And I make that point to folks. In fact, I said, well, hey, before you blame me, there were folks here before me that apparently you voted for that said they wanted these services or these whatever those IOUs were used to pay for. So here we are. But let's assume that there were no IOUs, that the fund was never borrowed from. Would we be talking about Social Security today?
We still would be, because
Why?
the amount of tax revenue that is estimated to be coming forward in the future is not enough to pay the benefits we've promised.
So this is a revenue problem?
It's a revenue problem and it's a benefit problem. It's an imbalance. So when looking at any sort of pension plan, you have to look at revenues and you have to look at outflows. So right now they're in balance. They're not in balance. So either you have to reduce benefits or you have to raise revenues or a combination of both. There's no magic means.
Or account for living in the 21st century. For example, what is the average retirement age now versus when Social Security started? And perhaps more to the point, what is the average lifespan of an American now?
The lifespan's a lot longer. I mean, when
Right.
Social Security was first started, most people, when they got to 65, if they lived to 65, were on benefits for maybe 7 years.
So isn't that a part of the problem?
That is, well, living
Or
longer is
that-
not part of the problem. I think that's a great thing, but it's a bad thing for the Social Security trust funds,
Right.
and I think
But
that's
it's
the
not
fiscal
just
problem.
raising revenue, withdrawing, or lowering benefits, it's, we're living longer, and isn't it also true that we have more white-collar jobs now?
Yeah, we have more white-collar jobs, and part of the reasons why defined benefit plans have been transitioning more to DC plans is that we are actually having more frequent job changes. If you look back at the 1990s, the top 10 market cap companies were Ford, GM, Chrysler, had 100,000 employees each, and they stayed with those companies for 30 years. Now it's Apple,
So
Google, and
raising
Facebook, and
taxes
they don't.
won't solve this, by itself at least.
If you wanted to do it just by taxes, you'd have to do a 21% tax increase today just to make the shortfall.
Right. And you're not a politician, but what's the political reality of that, in your opinion, as a taxpayer and an American?
I don't think it's very likely that anyone in this room who voted for a 20% tax increase would be reelected.
Right, thank you. I'm also very interested, Dr. Fichtner, I hope I get time to ask the others questions, but I'm not sure if I will. The current Social Security system, I'm paraphrasing you, is a disincentive to work and saving. So what would the model look like then?
Well, you would
Incentivizes work and saving.
You would change something. So one thing that Mr. Weber mentioned is that some people go back to work once they even start getting benefits. The retirees. So we should stop thinking about retirement as being something that means you no longer stop working, or getting benefits as being something that says you no longer work. We should disconnect those. Some people will continue to work because they enjoy working. Some might have to, some may want to. But if you're collecting benefits and working in retirement, you still have to pay the payroll tax. But that does not get you any additional benefits down the road. So why don't we give some payroll tax relief to seniors who have already paid into the system 35 or 40 years and say we're no longer going to charge you payroll taxes, whether you are collecting benefits or not. If you're working past a certain year, you wouldn't pay it. That would encourage seniors to continue working, whether they wanted to because they enjoy working, or if they had to for money, they wouldn't be then having to pay the payroll tax. They'd have more after-tax income. We would also change the benefit formula to be more based on every year of work as opposed to 35 years of work and an average. That penalizes. If you get to the point where you've worked past 35 years, each additional year you work either replaces a lower year or is considered a non-zero year. So you're paying into a system, not getting the added benefit for it, and it's a discouragement to working later in life.
Thank you, I yield back.
Thank you, sir.
Fascinating. Mr. Liu, you're recognized for 5 minutes.
Thank you, Mr. Chair. I want to thank the panel for being here. It has always struck me when I come to hearings like this, where we're dealing with projections 2 decades out, that there is a level of absurdity to that, right? So, Dr. Fichtner, in your paper, you do say that people estimate that by 2035, Social Security Trust Fund is going to, basically run out and they're going to have a 25% cut. No one really knows, right? Because you all can't even tell me in 2 years what our tax revenue is going to be, let alone 20 years. And the notion that we have concrete right now, with confidence that yes, there'll be a 25% cut in 20 years, or we need to raise taxes by 21% today, there is a level of absurdity to that. But having said that, we are the Budget Committee. Numbers and years make us feel better. I'm not against projections. I just want people to understand we should not attach any high degree of confidence to these projections, because really we just cannot predict that far out in the future. Having been in California State Legislature, our budget would swing, just percentage-wise, huge amounts within 2 years. Same in the federal government, I see that happening. But we'll deal with the projections because we have to have some sort of projection, just tend to sort of show a trend line. So on page 5 of your paper, you have, I think, 8 potential reforms to Social Security. The overwhelming majority of them are benefit cuts. There's actually nothing in here to increase revenues, and I'm just wondering, is that an ideological view, or is there some sort of academic reason for that?
It's a little bit of both, sir. So one, I would caution on projections, and your point about not being able to forecast 20 years out. If we were trying to pick who the Super Bowl winner was, I think I would agree with you. But we do see some trends. And the Social Security trustees, if you look over the last 12 years, the insolvency data has ranged from 2029 to 2042. So we are pretty confident that if we don't do anything, we are going to face some financial shortfalls. Now, you're right, there could be a period of extreme financial growth, economic growth. We could have another recession, which would make things worse, but we're confident that something has to be done. What you can do is either raise revenues or lower benefits. And the reason I don't focus on the tax side is I do think that's a further disincentive to work right now in savings. And I'd rather see things more on the structural changes. And on the benefit side, you could increase benefits for lower income workers while reducing it for higher income workers, and do that in a way that's revenue neutral, even helps the trust fund. And what I would caution is focusing more on those who need the help, and on those who don't. There was some rhetoric about having the rich pay their fair share. There's a rhetoric against tax cuts for the rich. Why do you want to give more benefits for the rich? That's not where it's needed. It's needed at the lower end, not the higher end, sir.
Thank you. So let me follow up on that. There is a bill introduced in Congress by Representative John Larson that says we'll keep the Social Security payroll tax cap at, I think, $118,500. We then have nothing happen till $250,000, and then we start taxing again. So two questions. One is, do you think, what the author says is that will largely solve their imbalance? When do you agree with that? And second, what do you think of it just sort of policy-wise?
Keep in mind that if we raise the cap, whether we're eliminating it or raise it, the way the Social Security benefit formula is now designed, you also get higher benefits. And so when we talk about the idea of raising the cap, we should also talk about whether that means we're going to raise benefits for Bill Gates, Warren Buffett, for myself as well, for those who are above the income cap. To your question about the solvency, raising the cap alone will no longer fill the Social Security shortfall. 6 years ago, when I was working in the Social Security Administration, I signed 3 of those trustee reports. I was the secretary to the Board of Trustees. Back then, 6 years ago, we could have just raised the cap and solved the problem if it was just on the tax side. We're losing our ability to do these changes now. Anything that goes forward from here is probably going to require changes to benefits and changes to revenues, because we've lost all other options by waiting.
Thank you. And then one more question. Some states, such as California, are trying to mitigate the retirement issue by letting employees sort of having a portion of their salary go into a separate savings fund for retirement. What is your view of that, and do you think states should be looking at doing that?
I'm in favor of based about any plan that would help people save for retirement, including the California state plan. Oregon is trying one as well. There is a concern that for lower income people, private financial markets do not see them as being financially profitable enough to offer them low income savings accounts. I think that's a mistake, and I think if the states can fill that role, that'll offer some competition and probably show the private sector that those people are worth having as clients. So I'm in big favor of states doing that as well.
Thank you. I yield back.
Gentleman's time has expired. Mr. Sanford, you're recognized for 5 minutes.
Hello? Oh, got it. I remember seeing a movie that was produced, I think, by Al Gore that talked about sort of the long run with regard to CO2 emissions and its implications in terms of climate change and other. If you take that same dire warning, if you will, that he laid out, Erskine Bowles, who was Clinton's former chief of staff, ran a commission, Bowles-Simpson, and in it he talked about the most predictable financial crisis in the history of man. He believed that that was what was coming based on the very numbers that we've been discussing today. So I guess it's Alcohol Anonymous that says, you know, the first part of dealing with the problem is recognize you got one. Would every one of you agree that folks at or near retirement are facing a looming crisis or problem if we do nothing?
Yes.
For some Americans, for some they're doing just fine. And I want to make sure.
I got it. Bill Gates, he's fine. I got it. But for the vast preponderance of Americans.
If we do nothing, they're going to be facing problems. Yes, sir.
Okay. So I'd go to the next step, which is to say, all right, we have an agreed upon problem. Would you go to the next step, which is to say, ultimately, insolvency is irrelevant. I remember in a finance class back in business school way back when, they said ultimately businesses don't run on balance sheets, they run on cash flow. And what ultimately matters as it relates to trust funds is cash flow. In that regard, if you look at what's already begun to happen to Social Security, other funds out there, we have negative cash flow, and the negative cash flows are going to substantially grow as we have this wave of baby boomers marching their way toward retirement. would you agree that our real crisis is not at the date of insolvency, but at the date wherein we're not able to negotiate, if you will, based on the unified budget? Do we put money toward defense, or do we put money toward retirement? That is a much earlier date than the date of actual insolvency of the trust fund. Would you agree with that?
Sure, the longer we wait, the harder it is. Pay me now or pay me later.
And to your point, Congressman, on cash flow, I'd say we've passed that time. It's not coming. We've already passed it. So yes.
I disagree that it's I mean, we have already passed it. I disagree that it's a major milestone.
Okay. So why, just to play devil's advocate, why would you say it's not a problem?
Well, the trust fund exists precisely for that reason. This was planned. We built up the trust fund knowing that we were going to need it. And people make a big deal about words like deficit or cash flow deficit, and it really doesn't matter. Social Security cannot borrow. It can only spend what it's already saved up. So right now, it's in a phase where it's in a cash flow deficit. It will soon, in a few years, be in a phase when it's an actual deficit, but that doesn't mean that it's contributing over the long run to the public debt. It cannot do so because it's prohibited from borrowing. It can only dissave what it's saved.
I would respectfully disagree, and I mean, the whole basis of a unified budget is you take from anywhere and you spend anywhere, and so there are absolute IOUs, to your point, that represent the future taxing authority of the United States government, but they're only valuable in as much as you can get those taxes out of folks to curry those benefits. And so if you look at the history of pay-as-you-go systems, I guess it was von Bismarck that originally designed it. You know, Ida Mae Fuller was the first Social Security recipient in our country. I think it was back in 1935. She got paid in like $35 into the system, and she got like $35,000 out. Needless to say, she loved it. The history of pay-as-you-go systems is that they're wildly popular in the first generation. Can you give me an example of a pay-as-you-go system in the world that has been wildly popular as you go 2 or 3 generations in?
Yeah, I don't have a problem with a pay-as-you-go system. We have a pay-as-you-go system for public education. You know, we assume.
Wait, but I'm asking, can you give me one example of a system that has sustained popularity and or solvency 2 or 3 generations in?
Social Security. I mean, we have a pay-as-you-go system, and it's working fine.
This hearing, which is to say, we're approaching insolvency.
The thing is that with this, we have a pay-as-you-go system that is a partial advance funded system. The partial advance funding is in the trust fund. And if you have that trust fund to deal with demographic bulges, which is what we face, inevitably at some point, you're going to be drawing down on that trust fund. And when you do, automatically, you're running a deficit. And there's nothing wrong with that. That's exactly by design, and that's the way it should be working. It's not a problem. It's only a problem if you scare people into thinking it is.
That would not be the history of von Bismarck and the German system and a variety of other systems around the world. But we'll come back to that. I've got 5 seconds left. I want to lay out one query, which is, how much would it take to fully fund Social Security for the next 25 years? Does anybody have that number?
The answer is to change the way the benefits are and make other changes in the formula.
No, I understand. I was just looking for a number if anybody happened to have it.
Gentleman's time has expired. Mr. Ginta, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to the witnesses for being here. I think this is an incredibly important issue, particularly in my home state. We have a rather high percentage per capita of seniors and those who are receiving Social Security benefits, and this subject matter comes up quite a bit when I am back home. First, I want to ask Mr. Weber, how responsive do you feel Congress has been when dealing with the challenges that we face, the fiscal challenges with both Social Security and Medicare insolvency?
Yeah, we polled our members, and that's one of the reasons why you hear people saying there's an anger in America and that people have lost faith in the government, and that's what this hearing is about, restoring the trust. So I would say that's an accurate statement, unfortunately.
And you have a presence in every state in the country?
Yes.
And this is across?
Yeah, across the board.
Okay. So it sounds like your members at least want some action, want some responsible action. Mm-hmm. And probably, maybe it's not fair for me to assume, but do your members also want to address this in such a way that is not just fiscally responsible for Social Security and Medicare, but also to the general economy.
Definitely. You know, years ago now, we can say that the Tea Party was formed mostly because of the deficit. You know, that was the main point that people joined the Tea Party. They were worried that we were headed in the wrong direction. And I'd like to mention that the ranking member, I think, succinctly pointed out some of the contrasts between different positions on both sides of the aisle. And what we're trying to do is to focus on the common ground, such as fixing COLA, for example. You know, we all agree Congressman Larson's bill addresses the fact that COLA does not help the poor elderly as much as it should, and we have proposals that do the same thing. And that's the kind of thing, if we can get together and work together and say, well, let's find out where we agree on, and one after another, go on the point. Should we set the age back, for example? Let's agree yes or no. Should we raise the Social Security tax limit? Yes or no, and you know, what kind of adjustments can be made? And that can be solved quickly. I actually think if this committee, combined with the House Ways and Means and the Energy and Commerce, put a number of select people together and formed a special committee between now and September, you could solve Social Security.
Well, I agree. I've got a proposal myself, at least to, in the short term, provide COLA assistance to retirees.
And that's bipartisan, right?
It is.
Yep.
It is, and in part because the cost of living for seniors increase, I think, is different than other populations. When I talk to seniors, they communicate to me that health care, prescriptions, food, their housing costs are significantly weighing on their overall budget, which is not to say that those things don't affect me, but they affect me and my family differently than it would a senior. It's actually much more expensive in many circumstances for a senior. Wouldn't you agree with that?
Yes, definitely. And there are ways to address that, and I think the COLA is the key thing to helping the elderly poor. Those are the people who are hurting the most, and those are the ones we should address first.
Well, I appreciate your work in this arena, and I hope that we can come to some reasonable and rational resolution on not just the COLA issue, but on the long-term solvency. Right. I want to go to Dr. Gottlieb real quick. Are there ways in which you feel Congress and the federal government can use the private sector options to expand or deliver Medicare?
Well, look, I think to the extent that we can allow private plans to compete for senior citizens and for the dollars and for beneficiaries enrollment, we're going to have the opportunity to see more innovation on the delivery side, particularly. We were talking about that this morning, introduced. If you look at Medicare Advantage, for example, where we have a private market solution to trying to structure the Medicare benefit, and you look at what the Medicare Advantage plans have done, even in a tightly regulated environment where their profitability is controlled, they've introduced some real genuine innovations in delivery of care. And I'll just cite one. A number of Medicare Advantage plans have rolled out these facilities that aren't hospital emergency rooms, stand apart from the hospital, but can provide short stay assistance to senior citizens who might need a 24-hour diuresis for an episode of heart failure and an infusion of antibiotics for pneumonia. Rather than bringing them into the hospital, they get treated in these facilities. That's a real innovation in care.
Gentleman's time has expired. Mr. Blum, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you to the panel for being here today. Appreciate it very much. I've got a lot of questions. So, and first of all, Dr. Fichtner, it's Fichtner, correct?
Fichtner.
Fichtner.
Thank you.
I'm glad you're over the cap for Social Security.
As am I.
Congratulations.
Thank you.
It took a while, right?
Yes, it did.
Mr. Weber, you've held town halls with members of your group, is that correct?
Yes, sir.
I'm a freshman, and it pains me. I'm a career businessman, so I want to solve problems. It pains me to no end that every time on the campaign trail, when I brought up Social Security and Medicare and how we need to fix it, the issue was demagogue. by the other side. I say we need to fix Social Security and Medicare. The other side spends $1 million in ads saying, I want to get rid of it. Now, it's tough to have a conversation, and it's tough to solve these issues when that's the environment politically we're operating in. Do you feel senior citizens are ready for candidates, for congressional members to have that conversation?
That's a good question. We poll our members every week on different subjects, and there's a big disappointment in the lack of action from the Congress. That's why, again, I salute this hearing, except we've got to speed it up. We've got to, as the good doctor pointed out, we are out of time, and we have to act soon. There's so many things we can do if we work together, and I wouldn't say so much one side does this and the other side does that. You know, we have traditional I guess, positions on certain issues. You know, one side is known for this, the other side is known for that. And I think just like the disability income was solved, even though temporarily, I think we should get together and work with good ideas. You know, we've looked at some of the bills that Democrats have proposed, some of the bills that Republicans have proposed, and I look at it and I say, you know, if we could take this and compromise here and take this from this side and this from this side, you could put together a bill that would work. Right now, Social Security is like an airplane that is taking off for a flight and it doesn't have enough gas to get to the destination. So while I was in the Air Force and we did in-flight fueling, I think we've got to take some strong action right now.
Any other comments on that question?
Well, actually, Congressman, it's a good point to bring something up because Ranking Member Yarmouth mentioned about thinking holistically and not just looking at a vacuum. There are areas we should not let the perfect be the enemy of the good. President Obama has a few proposals in his 2017 budget to help retirement security, including open MEPs for people who change jobs or employers who are small enough and want to band together. There are some for auto enrollment, which would help people save for retirement through private savings accounts. And one is a change to the Social Security benefit formula, which actually has been also introduced in the House by Congressman Brady and Congressman Neal from Massachusetts, so a Republican and Democrat. And it's going to be marked up in the Ways and Means Committee today. It's bipartisan. It would ensure fairness for all Social Security beneficiaries. It would help lower income workers. It would help women who've done some service and non-covered employment like teachers. It's a chance to do something. It won't solve Social Security, but it'll help. And we should do those things where there's bipartisan support, and those are the things we should do immediately.
Medicare. The underlying problem in Medicare, I think, is health care costs. And I don't know the exact numbers. I'm sure someone here does. Healthcare. It's safe to say healthcare costs have increased more than the cost of living, yes, more than inflation rate, probably by double or triple. If through free market principles we could reduce the increases in healthcare, let's say cut it in half, what would that do to Medicare? Mm-hmm. How much longer would that extend the solvency of that program? Cut it in half, the increases. Maybe the increases in healthcare just are the same as inflation.
It would extend it for several years, and Dr. Gottlieb might have better numbers for you. But
yeah, it would extend. I mean, if you were to cut it in half, it would extend it. I don't know the exact numbers, but it would extend it, you know, a substantial number of years from the current projections. But remember, would
that be a considerable?
It would be considerable. It would certainly be probably decades. I don't know offhand. I can compute the numbers. I've never had that question put to me. But remember, we've capped the rate of growth of Medicare. IPAB puts Medicare on a budget and caps its rate of growth and ties it to CPI. I've had discussions here today about tying Social Security to cost adjustments that more accurately reflect the costs that seniors are facing. With Medicare, what we've done is we've capped the rate of growth and tied it to something that doesn't approximate the rise in medical costs, because medical inflation has always outpaced CPI historically.
When you say caps, doesn't that sound a lot like rationing?
We've fixed the pricing. I mean, this is the debate we have about how we're going to cap the rate of growth Medicare, whether you're going to use premium support and put consumers in charge, or IPAB and put the government in charge.
Gentleman's time has expired.
I yield back time. I don't have.
Thank you. The gentleman from Georgia, Mr. Woodall, is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you for holding the hearing. Dr. Gottlieb, you're talking about healthcare inflation. You know, penicillin's never been cheaper than it is today. I can go to any grocery store or drug store in the country and get a 90-day prescription for about the price of a cup of coffee at Starbucks. We've done amazing things to collapse costs. The Social Security conversation frustrates me because we know what the 4 or 5 levers are we can pull, and we just have to have the courage to pull them. Candidly, I've talked to a lot of smart people. I don't know what levers to pull, and I read in your testimony a pretty disturbing analysis that my dad is one of the folks who had an aortic valve issue. I always thought the reason we had to have patients documented to not be appropriate candidates for the open chest procedure was because the catheter procedure was more dangerous and less reliable. But in your testimony, you've laid it out to be a strictly financial decision made by folks in government who have to monitor the pennies that have an impact on healthcare decisions down the road. Number one, am I understanding your analysis of that correctly, that you make decisions, that decision in particular and extrapolating others were made for financial reasons, not healthcare reasons?
Well, Medicare certainly had some legitimate public health concerns and clinical concerns about the product, which is its long-term durability and whether or not patients who are going to live many more years should get an open aortic valve repair instead of this minimally invasive approach, because they're going to have 20 years to benefit from it. If the device only lasts 5 or 10 years, they're going to have to come back for another repair. But that said, their concerns and how they implemented the policies went beyond just addressing those concerns, and it really did try to address their budgetary concerns. And this isn't the first time the agency has done this. I mean, the inclination of the agency, and I've worked there, is to try to smooth the introduction of technology that could create a bolus in spending. And they put in place some restrictions that were quite extraordinary. For example, you had to have a cardiothoracic surgeon and an interventional cardiologist in the OR suite at the same time. There's really no reason for that. They argued that, well, if the operation goes bad, which it really does, you'd need the surgeon on hand to convert to an open procedure. If that's the case, then why not just let only surgeons do it? They required patients to get 2 different certifications from physicians that they weren't candidates for the open procedure before they can get the minimally invasive approach. That requires 2 separate visits. We're dealing with patients with class 4 heart failure. They're basically what we call in medicine cardiac cripples, meaning they cannot walk a block without having to sit down because they get so short of breath, and you're requiring them to come back twice to the hospital to see 2 different doctors. They can be certified 3 times because the physician who's going to be doing it is also going to certify them that they're not a candidate for the open procedure. Those were put in place in part because of budgetary considerations. And when I was at Medicare, the big issue was implantable defibrillators, where Medicare put in place extraordinary restrictions on who can get those, and ultimately scientific studies debunked what Medicare had done. And in the case of TAVR, subsequent science debunked what Medicare did in this case as well.
Well, I started with the story of generic drugs at Safeway and Giant, because I'm going to go buy those generic drugs. I'm spending my money, and I'm going to go make sure I'm getting the best value. Mr. Sanford asked about pay-as-you-go systems that are sustainable in the second and third generation. I can't think of a single third-party payer system that doesn't have that kind of oversight on it. We can argue about whether that oversight is effective or ineffective, but can you imagine a scenario where that oversight doesn't exist, where we actually let clinicians make the clinical decisions? Can you imagine a third-party payer system where the bureaucrats and the bean counters aren't involved in that decision making?
Well, I think it's the question. There's going to be rationing in the system. That's the reality. The question is, who's going to do the rationing? Is it going to be done by Medicare and more of a central authority, or are we going to allow actors in the marketplace to make those decisions, consumers or providers? I mean, we're making a decision to shift the node of decision-making, if you will, and rationing to both providers and Medicare and away from consumers. That seems to be a deliberate decision that we've made in the last 5 or 7 years. I would argue, I think that the more we can shift these kinds of considerations onto consumers, the more we're going to have people be able to exercise discretion in one of the most personal decisions that they're going to make, which is how they get medical care.
It is that last sentence that I'm going to replay over and over and over again. You're exactly right. It's not if we're going to ration, it's who's going to do it, and it's who's going to make these most critical decisions for us. If it had been called the Save Seniors from Losing Their Doctors fix instead of the doc fix, we would have solved the SGR long ago. The only people who have skin in this game are our parents and grandparents, and I thank you for that.
Gentleman's time has expired.
Mr. Chairman.
Thank you. Fascinating questions. I appreciate the panel. each of you, Mr. Weber, Dr. Fichtner, Dr. Morrissey, and Dr. Gottlieb. Your testimony and responses to our questions have been remarkably helpful and enlightening for us on an issue that is incredibly important. And I'll take home a lot of things. One of them is the unanimity that all of you have about the need to fix the challenges that we face in these systems, so that we can keep our promise to the American people and to our parents and our grandparents. Please be advised that members may submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. Any members who wish to submit questions or any extraneous material may do so within 7 days. This hearing stands adjourned.
Thank you, sir.